All right, so with that, we'll go ahead and get things started. So my name is Sarah Blanca. I know some of you are familiar names, at least in the chat box. And for those of you that I don't know, you're just friends I haven't met yet. So my name is Sarah Blanca. I work for Optum Behavioral Health. I serve as the Director for Crisis Solutions, looking at innovations for us nationally in that crisis space. And I'm excited to be your host today for the Crisis Jam. All right, so we got a little teaser today of what we're going to be talking about with Dr. Pat Deegan in just a few minutes for dignity in crisis care. So it's exciting. And we've got on here all the states and different Medicaid authorities that are represented, all the different organizations. If you don't see yourself on that list, make sure you let us know so that we can add you. Today, I believe we're excited to welcome the National Governors Association for the first time. So that's exciting as well. So continuing to spread our reach. And in case you ever miss one of these, hard to believe you could do that, but if you ever miss a Crisis Jam or you want to go back and watch something again, you can always go to talk.crisisnow.com and check it out, as well as any of the other materials that are referenced here are usually posted on that site. And here we've got highlighted our call from last week with Representative Lauren. And a little bit of crisis in the news. So there was a recent NBC news article highlighting 988 and kind of states preparedness for that. So you can definitely check that out as well. And I believe I'm going to pass it over to Shannon to talk a little bit about NAMI and the 98 day of visibility. They have a really great site right now with the reimagined crisis response. There's some great quotes up here that I think are really powerful. A lot of folks are kind of anticipating the launch of 988, which is a momentous moment. But I think we also have to put in perspective that, there's so much more work to be done. So Shannon, I'll let you kind of talk a little bit more about this slide and a couple others here.
Yeah, thanks so much, Sarah. We are in the middle of NamiCon this week, and we are incredibly excited that tomorrow, we're going to have a 988 day of visibility, and we're really going to try to continue to spread this message. And I think, in contrast to what you saw, have been seeing coming out of the media in terms of the system isn't going to be ready, NAMI is really trying to encourage everyone to look at this as just, one point in time, a jumping off point to really make sure that we continue to advocate for the resources that are necessary to put into place the real response that people need when they have a mental health crisis. And so you're going to be seeing that in a lot of our messaging, really hopeful messaging, and you're going to be able to hear a lot of that tomorrow during our day of visibility. So can I get the next slide? What you'll see in the second main bullet down there, so tomorrow, June 16th, at 1:50 p.m. Eastern time, you can use that link, that reimagine.crisis.org-98 day visibility, and you can follow us at NAMI Advocacy to kind of hear our message and share it and try to continue to spread the word. We also wanted to make sure that everybody knew that we're going to be ending the jam a little bit early today to make sure that folks can join the fireside chat that will be happening at 12:55 with Assistant Secretary Delphin Rickman. She's going to be speaking with our CEO, Dan Gillison, and probably talking a lot about 988 and kind of this opportunity to expand crisis care. So we'll make sure we drop that link into the chat so everyone can access it. And please, if you have time, join us at 12:55. Next slide, please. And I believe Margie is on the call today. And I just wanted to take this moment because I think it's really important to acknowledge acknowledge people who are out there really leading the way amongst their peers. And so everyone on here is really working hard on crisis services. And this year, NAMI is honoring Dr. Margie Belfor with the Sam Cochrane Criminal Justice Award. This is an award that is in honor of Sam Cochrane, who is one of the founders of CIT, started it back in the 1980s. In Memphis, Tennessee, and has really been about recognizing people in the who work in criminal justice work that are really leading the way on mental health. And, you know, just an important note here that I think is really recognizing where the conversation is going. Margie is the first mental health provider we've ever given this award to. Historically, we've always given it to judges or police chiefs, but this year we really felt that, you know, Margie's challenging of the way we provide crisis services, and the way we address, you know, the whole person. You know, often people who have complex needs really get lost and routed into the criminal justice system. And I think Margie's challenge to all of us to really think about how to serve those people within the mental health system is really kind of changing the way that we think about diversion. And so we really just want to praise Margie for all that she's doing and just thank her so much for really leading the way.
Well, thank you so much. I didn't realize I was the first mental health provider. So that makes this even all the more an honor. Thank you so much.
Yes, very well deserved, Margie, very exciting. So thanks, Shannon, for those updates and for being able to share with us some of that information honoring Margie. That's very exciting stuff. And now for our quote of the week, which comes from our featured presenter as well, Dr. Pat Deegan. And our quote is that people need to have the dignity of risk and the right to fail. So I think that's an awesome quote, and I think it'll pair nicely with the presentation that we're about to enjoy from Dr. Pat Deegan here. So I have the honor of introducing Dr. Pat Deegan, a clinical psychologist, researcher, person with lived experience, disability rights advocate, so much more. We're really looking forward to hearing what Pat has to say. She was here, I think, for like a minute or two in the roundtable like a month or so ago, and everyone kind of loved hearing from her, and now we get to hear a little bit more. So Pat, I'm going to go ahead and turn it over to you.
Thank you very much, Sarah. Shout out to everyone that's out there. I can't see you all, but I do believe you're there, which is a good thing. I was asked to put together some comments that reflect my thinking and my work around the whole area of recovery and the psychiatric care consultation within a crisis context. And I spent way too many years working on this area, so it's going to be a challenge to say it all in 15 minutes, but thanks for having some time to hear me out today. If I could have the next slide. You know, I think that the fundamental insight I'm sharing with you is that when those of us diagnosed with a mental illness, a mental health challenge, are in a room with a psychiatric care provider, there are in fact two experts in the room. And what this means, of course, is that the individual who is in the room talking with the psychiatric care provider about moving through crisis and moving towards the life I want, that the key is to recognize that there are two human beings, and that's the common ground of our shared humanity on which we meet. Okay, and that is the ground from which all of the work I'm going to talk about happens. And that I thought I'd begin with just a brief reflection on dignity, because dignity is a critical part of providing quality crisis care to individuals who are making a fiery passage very often in their lives. So what is this dignity? What is dignity? Well, dignity is about worth and about value, at least if we look at the dictionary. But of course, dignity is not about the value that we might attach to a fancy car or to a big paycheck. That's not prestige or fame. That's not the kind of dignity that we're talking about here. Rather, I think our dignity is rooted in our very fact that we are being and we're becoming, right? And that what it means to be a person of dignity is that I don't have to earn that dignity. It is, if you will, my birthright. And that being itself, being a human being itself, is to be of dignity. And importantly, I think it's also important to recognize that dignity is about becoming, the freedom to become and to fulfill our human potential. Dignity is the freedom to become incurably, unapologetically who we are, right? So the goal isn't normalcy, right? The goal is to become the unique, never repeated gift that we are. If I could have the next slide. When we experience dignity, and I'm thinking that those of us on the call have experienced our own dignity, these are some of the things that I think are fundamental and that occur. And in particular to this conversation, feeling seen, feeling heard, feeling understood, feeling that I am dwelling in a dignified place, and feeling that my culture and my heritage is recognized and honored are key indicators, quality markers for dignity. And each and every crisis care, respite, transitional program, setting, must reflect all of these dimensions of dignity. Next slide, please. That said, when I was a teenager and was diagnosed with schizophrenia, this was not my experience having my dignity affirmed. In fact, I would say that in those early days, my experience was of dignity being violated. My dignity being deeply wounded in the context of mental health services, right? And a key part of that for me, and I think for many others, is the experience of being profoundly over-medicated, being treated against our will, and also having very little say in what was happening for me in the context of a hospital setting in my case. And I think the emphasis on medication and using and meds being used in such a way that they were suppressing my being, so that really that combined with the message that I had a disease and that I needed to gain insight into schizophrenia and the disease that I had, and that I needed to essentially retire from life and take high dose antipsychotic
I worked on that
medications.
this morning, and this is what I sent to the other three.
I'm sorry, I can hear somebody speaking. If you could mute yourself, thank you. So this experience of being over medicated and really suppressed, my being suppressed, sitting on a couch and staring into space all day and being told that I could never really have a life. The best I could hope for would be to muddle by. And if I had to characterize what were my psychiatric care consultations, because meds are really our focus today, I would say that there was a chasm between myself and my psychiatric care provider. So I might say something like to the effect of, I didn't have the big words at the time, but I feel sedated. And the perspective of my care team was, well, you're not psychotic, Ms. Deegan. And I would say, well, I still hear these distressing voices. And they would say to me, but you're not shouting at your voices anymore, meaning my behavior was controlled. I can't think very clearly was my experience, but you're not thought disordered anymore, Ms. Deegan. And I feel like the meds are controlling me. And my team's perspective was, you are more in control now. I'm not myself anymore. Meds have changed me in ways I don't like. You've returned to baseline, Ms. Deegan, right? So there's a chasm in the perspective. We literally have not found any common ground on which we can meet in order to help me move through the challenges that I'm experiencing. And so if I could have the next slide, please. My work over these many years now have really focused on a variety of ways that we can begin to operationalize how to help folks and how we can activate the care team to support people's well-being and to support the kind of common ground, the finding of common ground, and protecting human dignity in the context of these psychiatric consultation in crisis settings. We need something new. We need something other than the old paternalism. We need shared decision-making. I have a vision, and the work that I'm doing currently I call it medication empowerment. How can the peer support workforce in crisis settings be mobilized to support people, to prepare to participate in having a different kind of conversation with the doctor? Let's watch one example of what could happen in crisis settings. Imagine a peer specialist, next slide, please, and an individual watching this video during a transitional crisis stay.
How to work with a doctor. Imagine my doctor and I are working together on a jigsaw puzzle. Each of us has a few pieces of the puzzle. The doctor, who is an expert in medicine, knows a lot about how psych meds can be helpful. But I am an expert too. I know what my hopes and dreams for my life are. The doctor knows how to help if meds cause side effects, but only I know how side effects feel inside my body. The doctor knows how to support me through the hard times, and I know how to ask my friends for support, and that also helps me get through the hard times. Meeting with the doctor is a lot like working together on a jigsaw puzzle. When we meet, there are two experts in the room. Each of us has important pieces of the puzzle. Of course, the doctor is an expert in the practice of medicine, but we are also experts. We are experts in ourselves. We are experts in how our body feels. We are experts on what we want for our life and what our values are. Each time we meet, we bring our two perspectives together to figure out how best to reach my goals for my life.
Okay, if I could have the next slide. This short video could be used by a peer specialist in helping someone prepare to participate in the meeting with a psychiatric care provider in a crisis setting. And then there's a worksheet that I could use to help prepare my questions, concerns, etc., and going into that consult. Another tool that I've created are a series of short videos that capture the common challenges that those of us who use psychiatric meds experience on the journey to use meds to support our recovery and to get the life we want. Some of the challenges include, are meds helping you? I'm not motivated to take meds. I'm concerned about how meds are affecting my health. It can be hard to trust a white doctor sometimes and trust that the medication I'm getting is right. Meds have changed me in ways I don't like. I like to get high. I don't like your meds, I like mine, right? I have side effects, I'm over-medicated, and of course, I'm questioning whether I can come off meds. So let's imagine, if I can have the next slide, that Darnell is coming into a crisis, say it's a 3 to 4 day crisis, transitional crisis place, and he had abruptly gone off his medications prior to coming into the support facility. And how are we going to help Darnell, who's going through a crisis, begin to amplify his voice so that he can actually be heard in that psychiatric care consultation, right? So imagine Darnell working with a peer specialist and exploring the challenges he's experiencing, right? And then being able to watch a related video. So Darnell checks off, hey, I like to get high, and I like my drugs better than the drugs my psychiatrist gives me. Well, what do we do with that, right? And how do we prepare Darnell and invite him to talk about that? So imagine Darnell watching this short video. We're going to watch 3 minutes of it. If you can go to the next slide.
I like to get high. Getting high can sometimes bring us immediate relief from anxiety, depression, and other unpleasant emotions and experiences. Sometimes it seems like the only thing that really works. Other times, it seems like getting high might make things worse or even create other problems. And that puts us in a tough place. Sure, we want the immediate relief that comes with getting high, but we don't want our anxiety, depression, and other challenges to get even worse over time. Our doctors may advise us to cut back or stop our use. There are a few reasons for this. Sometimes the drugs or alcohol we use can have a bad interaction with the mental health medication we are prescribed. Sometimes getting high makes our symptoms and mental health challenges worse. And finally, sometimes drugs or alcohol prevent psychiatric medicine from helping us as much as possible. But even when we know about these risks, it can still be hard to quit or even cut down. Willpower alone rarely works. If we are thinking about cutting back or quitting altogether, there are steps we can take that have worked for others. Some find it helpful to talk with the doctor about medication-assisted treatment. If we don't want to cut back or quit, an important question is, how can I reduce the risk of getting harmed by my drug or alcohol use? Just like we might use sunblock to lower the risk of getting skin cancer, there are harm reduction strategies we can use to lower the risks associated with using. For example, if I like to get high on marijuana and I have mental health challenges, I might choose to buy from a cannabis dispensary rather than a dealer, so I lower the risk of buying weed laced with something toxic. If I sometimes experience paranoia or anxiety when using, I could use a strain with higher levels of CBD rather than strains with high levels of THC. Check out these worksheets for more harm reduction strategies.
So if I could have the next slide. And so what this means is that Darnell could go into his psychiatric care appointment prepared to talk with his doctor about harm reduction strategies that he might consider or might not consider in relation to his stay and trying to get to the life that he wants. And I think another final piece, and then we'll open it up, is that medicine is not just the pills that we take. Medicine is also what we do. Exercise is a very powerful antidepressant, for instance. So I call this personal medicine, the things I can do to support myself through some of the challenges I'm experiencing. And imagine a peer specialist workforce empowered to use personal medicine cards, for instance, for distressing voices, or personal medicine cards for anxiety, in order to be able to support individuals in getting the life that they want and making it through this transitional crisis period. So these are some of the ideas that I have about how we can bring voice and choice and reaffirm dignity in the psychiatric care consult during crisis.
Well, thank you so much, Dr. Deegan. That was a fantastic presentation, and really enjoy kind of that emphasis on, reaffirming dignity of those that we're serving and working with, and especially love those videos, kind of giving language to people to kind of help them advocate for themselves when they're in that room with their treatment team, and addressing some very real issues that often get ignored. So that's fantastic information. Really appreciate it. So now we're going to have a roundtable discussion of Dr. Deegan's presentation. So I'd like to welcome Eduardo Vega, Humanvation's founder, CEO, and Shelby Rowe, who's the SPRC director. So Eduardo and Shelby, I'd love to hear from you, just kind of your thoughts or a few words about what Dr. Deegan's presentation means to you, and just kind of your perspective on that.
Eduardo, I will let you go first.
Oh, I was going to let you go first.
Oh, well, then I will go first then. I was going to be polite, but I will go ahead and step in. Hi, everyone. Happy to be joining everyone. I'm recovering from COVID, so if you think my voice sounds different, you are right. It does sound different today. But I really appreciated Pat's discussion because it reframes, I think so many times in mental health care, we want to define what health looks like for those who are receiving care in our systems and framing it that preserving that dignity. Because in other healthcare settings, it's not necessarily as paternalistic as we still are in mental health. That as patients, we help define what healthy looks like for us with our different, that it's not, not all of us have to run marathons. Not all of us have to, have one specific number of our BMI, but yet in mental health, and listening, and I love the examples that she used in her presentation of, someone saying, this makes me feel bad. I don't feel well on these medications, but that clinician's definition of what health and well-being just constantly overriding that individual's experience. And so I think, as we move forward with 988, what does safety look like for that individual? And that is what matters, that dignity, to trust that they called the service and what does that look like for them, and not some definition by someone who may be an expert in mental health and crisis intervention, but not an expert in the life experience of that caller. So shifting back and being able to listen and stay collaborative. I'm going to hand it over to Eduardo because he probably has comments, but those really stuck out to me of what, we've got to be working collaboratively with those that we are serving.
Thanks. I really support your comments, and also very gratified to hear Pat centering dignity here. That's the one thing that I would say in my experience, and excuse me, in my experience, both on the receiving end of services, but also as a provider for many years working in early crisis counseling and community mental health settings, was really patently clear to me, which was that once you were a part of this system, you had to give up a lot of, you were expected to give up ideas of yourself, you were expected to defer to power systems and to the decisions of other people who were in the know about your life. And and I know that there is a better way. And the other thing I think is that, one of the things that Pat talked about, and this is really connected to the training that we do called Growing Through, which is about a crisis support model, or what we call a struggle support model. Which is about connecting on the basis of humanity, that we're all humans, we all suffer. Struggle sometimes is the key to our growth. What people call crisis a lot of times is the essence of an important personal change. Whether you're coming from a substance recovery model or some other, this recognition that people hit bottom, and those are terrible, difficult processes. But they're also important. They don't diminish dignity. They're part of our human journey, our individual journey. And I think that the other part that she pointed out that's really significant is that in that, that journey is towards becoming the people that we were meant to be, growing through times of struggle. If we support people with that model in mind, that what they're going through doesn't separate them from the rest of humanity, it doesn't make them less than we as providers, it's actually just part of their unique journey, then we can recognize that it's really a gift to be supporting people in that process. And we can start to take a back seat to center their needs and their growth first, rather than, in a certain sense, what services we have to offer. And I'm very excited, to say that, with dozens of providers in Illinois, we've been doing trainings focused in this model for, especially with a focus on engagement specialists, peer support providers. But anybody can really do this. It's really a matter of, us taking, going back to that, human dignity model, recognizing that the person we're serving or supporting is a human with all of the richness and the importance that they bring to our world. And then we recognize that not only are they a gift, but it's a gift, it's a privilege to be able to support folks through their most difficult moments.
Well, thank you both, Eduardo and Shelby, for those comments. I really like what you're saying, Eduardo, about it being such a privilege to serve people, especially in some of those most difficult times. That's something that I thought about a lot when I was working as a direct provider in crisis care, that it's really a unique opportunity and privilege to be there for someone when they're in those moments. Loved what Dr. Deegan was saying about the freedom to become who we are. And the perspective of kind of hearing those differing voices of, what the traditional treatment team may be saying versus what the experience is like of the individual that's being served. So wonderful conversation. Really appreciate everybody's contribution. There's some great comments in the chat as well. So really enjoyed that. And thank you, Dr. Deegan, for that.
Thank you.
All right, so now we're going to shift gears a little bit and hop into a hot seat for the Crisis Trivia Hot Seat. So today we have with us Linda Langford. Linda, do you want to introduce yourself real quick?
Yep, I'm Linda Langford. I'm from Education Development Center. I have worked in the suicide prevention field for between 15 and 20 years or so. I've done a lot of work with the Suicide Prevention Resource Center, with the National Action Alliance for Suicide Prevention. And for about the last year and a half, we have been working with Vibrant Emotional Health to support states and territories in their 988 planning and implementation grants.
Wonderful. Well, we are very glad to have you. And I hope that all of your wealth of experience can help you today in the hot seat. I'm going to go ahead and read you the question. And I'm going to try to read you the answers, but I'm going to be honest, the answers look to me like a foreign language. So we're going to do our best. So your question today is: the National Emergency Number Association, or NENA, master glossary of 911 terminology includes acronyms for the phone number and longitude and latitude data PSAPs receive from callers. So the question is, what are the PSAP and telephony industry acronyms for this data? So when I first saw the options here, to me, it looked like we're trying to figure out like a vanity plate or something, like making some words out of it. So it looks like the options to me, I'm just going to say them the way that I think they should be said, would be A, Annie and Allie, B, Edith and Archie, C, ENIP and ELT, and D, this is my favorite. I feel like this one should be Mork and Mindy. So we've got a poll up so that the audience can vote on what they think is the best. So we can certainly share that with you, Linda, and see kind of what they're thinking. But do you already know this answer? Is this something that you know right off the bat? This is not really our industry per se. It's kind of a one swim lane over.
I actually do know this answer.
Ooh.
I was sure I would not know the answer, but I did watch the FCC forum, enough of the FCC forum a week or two ago to pick this up. I feel like they should change it to D, even though it's not D. But
I
the
agree.
answer, but my answer is A.
All right, so you're going for A, Annie and Allie. The audience thought differently, but you seem confident and you are right. So Annie and Allie, congratulations, Linda, is the automatic number identification, ANI, and automatic location identification, ALI. The 911 operators receive an automatic display of the caller's telephone number and their precise address or geolocation. So absolutely, that makes sense that you would have picked up on that during that geolocation forum. So you really got something out of that in addition to the other things that you learned. So congratulations. I hear that, maybe a t-shirt is going to be coming your way, but if nothing else, you have the pride of winning at the Crisis Trivia Hot Seat. So thank you so much for that.
Thanks for having me. I love the Crisis Jam. So
awesome.
And, happy to be here.
Thank you. All right, so now we're going to be shifting gears again to talk a little bit about our Crisis Talk content for this week. We are really lucky that we have with us today Sue Murray. Sue, I understand it is the middle of the night where you're at right now. So we're particularly appreciative of your willingness to join us for the Crisis Jam. But we were hoping that you could talk to us just a little bit about this interview that you had with Dr. Phil Moore about the mental health improvements that came about in the UK during the pandemic. So welcome, Sue.
Great. Thank you so much, Sarah. And for me, it is good, very early morning to everyone. Look, for this edition of Crisis Talk, I spoke with two mental health leaders in the UK, and both of them agreed that the one positive that came out of COVID-19 for the UK was that the communities across the nation got accelerated access to mental health services. Dr. Phil Moore is a London-based GP and clinical co-director for Mental Health London, and he told me that in a matter of a few weeks, all of the national mental health trusts had 24/7 all-age crisis lines in place as an urgent response to the pandemic. Almost in an instant, they had reimagined the existing NHS 111 phone service for general health matters simply by adding the option of press 2 to take a person directly to mental health crisis centre. As with everything, we are hearing more and more technology is playing a really big part. And in the UK, they've got increased access to clinical databases that can match the person to better health care. And this helps to avoid that all too common problem that the person having to repeat their story ad nauseum. And we know that that's something that is really impacts poorly on people who are seeking individual help. They have backups to the phone service. The London ambulance service and mobile crisis services are available. And again, the technology plays an important part here. Text messages are then sent after the calls are sent to individuals, to their carers and to their healthcare providers, obviously with permissions. And those text messages are about the decisions that have been made and the actions that were taken in order to keep the person safe. Like many countries, though, the big challenge that Dr. Moore spoke about was that of the actual staffing of the health services, the staff that are needed to be able to sustain the services that are up or operating. And that workforce really does remain one of the biggest single issues for them to overcome in the near future. I also spoke with Sonia Mclean, who looks after the southern area of the UK, and she had no small task in opening up these services within her region. She had 5 different mental health trusts that she had to negotiate with to come down to providing one service. They're mental health nurses now. The services are operating. They're taking around 1,500 calls a month, and around 89% of those are actually being managed with self-care in the home. So that's having a huge impact on reducing the call on and the pressures on the emergency departments in their hospitals. Like the London service, the Southern UK has also got that consistent interaction between the various parts of the mental health service using those text prompts. And I think that was the thing that struck me as being so important, listening to both of them, was that the system is joined up and that whatever care is delivered is communicated to the person, their carers, and the healthcare professionals. So both Sarah and Phil really felt that the goal was to ensure, as I think we all want to ensure, that an individual is getting the right help in the right place at the right time. So read more about this in the current edition of Crisis Talk. And thanks very much, Sarah. I hope you enjoy it.
Thank you so much, Sue. That's so fascinating, thinking about how quickly they put that together. Definitely encourage people to go to the website, check out the full story there, but just some really exciting stuff that's happening. I know that James Wright is working to connect us with some leaders associated with that to maybe even bring us more on this topic, as it's really great information for us in the US to kind of learn from some of the workings that are happening over in the UK. So really appreciate your information, Sue, and your willingness to get up in the middle of the night.
Pleasure.
Thank you. All right, now I believe I'm going to pitch it over to John for some SAMHSA updates.
Thank you so much. Good to see everybody. I wanted to provide a couple of quick updates and then I'll pass it off to Richard McKeon if he's on the call. The first is that I wanted to provide a brief update on chat and text capacity. I know that we've talked a lot about our focus on operational readiness, particularly recognizing that there have been some significant challenges in chat and text response capacity in the system. And there is good news to report. Obviously, a lot more work to be done, but definitely wanted to let this group know that there's movement in a very positive direction here. So as an example, looking at response rates back in February, where for chat and text, we were at about a 26% response rate. In early June, we've moved now to a 72% response rate. And that has been really due to the incredibly hard work of Vibrant and the crisis centers to move that forward. And we're expecting continued movement in a positive direction, but just wanted to let people know that there is a lot of attention on that progress. And also related to that, I think we might have mentioned before that there is now piloting of local routing of chat and texts. That was initially 2 states, that has now been expanded to 6 states. So again, moving forward programmatically with building local capacity beyond calls and including chats and texts. And then quickly just wanted to provide an update on the formative research work that's happening in partnership with the Ad Council and the Action Alliance, ultimately driving toward a goal of developing a research-based communications campaign that will encourage life-saving actions. Part of that is a smaller piece of work currently, a formative research focused in on populations that we know to be at higher risk of suicide, as well as populations that we know have faced inequities in access and outcomes in the crisis system. So that work is starting to get underway with a plan to look at those particular communities, understand some of their perceptions of risk, motivating factors, barriers to help seeking, including what might be some challenges or barriers in using a service like 988 in terms of expectations that they have, who influences those communities with respect to help seeking behavior, and also looking at communication channel preferences with respect to health information seeking behavior. So we'll have more to report on that. But again, it's a piece of work that will drive ultimately toward hopefully a much bigger campaign that we think will be focused on behavior change and life-saving actions in support of the needs of these communities. And then I will pass it off to Richard for any additional updates.
Thank you very much, John. One of the things that we are most focusing on now is the crucially important area of 988, 911 coordination. We are preparing for a policy academy next week with 5 states, Maine, Georgia, Minnesota, Colorado, and California, focused on that topic. Are also continuing our coordination with the National Emergency Number Association, and have done in a number of ways looking to do deeper dives into some of the crucial issues in coordination around that. It is quite clear, of course, that in an issue as important as this, that there will be ongoing necessary work over a period of days, weeks, months, and likely years, and we are committed to that effort. So thank you.
Well, thank you both, John and Richard, for those updates. I think we're going to pass it off now to Megan Haupt from NASHBID to give some updates over here.
Great. Thank you so much, Sarah. And John, that's really exciting about chat and text and what SAMHSA is doing. Very exciting. And that chat and text is so important for adolescents, especially to have that access. That is how they most want and prefer to communicate in crisis. And so we wanted to really emphasize child and adolescent crisis systems, and to emphasize how important it is that they have different needs, different way of approaching crisis, that you can't treat children and adolescents in the same way you can adults. So we want to emphasize the need to really build up that children's crisis system and connect with school mental health as well. So we want to emphasize 2 papers. Both the co-authors were Sharon Hoover, who is an expert in child mental health and school mental health. One of the papers is Improving the Child and Adolescent Crisis System, Shifting 911 to a 988 Paradigm. And the other is Schools as a Vital Component of the Child and Adolescent Mental Health System. So we hope these 2 resources are helpful to you. And, thank you, SAMHSA, for your leadership. And we're also very grateful to Dr. Hoover for these resources. Thank you. Back to Sarah.
Wonderful. Thank you, Megan. So now I'm going to pass it over to another Sarah to give us the federal update on 988.
Thank you, Sarah. So I'll be quick today on the FY23 appropriations process. The House has announced that they plan to mark up their labor HHS FY23 bill starting next week. The subcommittee markup is on Thursday afternoon of next week, and the following Thursday will be the full committee markup. So we'll get a better idea of where the House is putting mental health programs for the next fiscal year as soon as next week. On the gun violence package that has been announced, that framework was announced on Sunday. So far, we've seen an outline of some of the draft policy specs that will be in the package, but so far not a ton of specifics
you've overpaid
on on what exactly all of those translate into. But we do know that the Certified Community Behavioral Health Clinic program
so if I were you,
of that.
So we're getting some interference and we really want to hear what Sarah's saying. So if you are not on mute, really would appreciate it if you could go on mute. Sorry, Sarah.
No problem. Thank you, Sarah. So yes, so I can put in a summary into the chat of some of the items that have been announced that will be a part of that, but so far Not all of them have been translated into what the exact policy specifics are. And they expect to potentially release text to that bill later this week. I believe they are probably drafting it right now. And the Senate hopes to vote on this bipartisan package by the end of next week. They'll be on a 2-week recess, so that will give a week for the House to hopefully get it passed if all comes together and get it signed into law before the July 4th recess. But again, several things need to happen before that is wrapped up. And then finally, just a quick shout out to the Bipartisan Policy Center. They had their webinar and announced their report, released it this morning on crisis care. That was, I believe, 11:30 to 12:30 today, but the recording I'm sure should be up on their YouTube channel at some point, as well as a report that was released this morning detailing their recommendations on the crisis care space, also on a bipartisan basis of what can be done to help improve the system and what their recommendations are. I will turn it to Joanna from AFSP to go over some more committee work.
Yeah, so we're expecting the Restoring Hope and Mental Wellbeing Act, the HR 766 reauthorization package, to go to the Rules Committee on the floor next week. So we've been monitoring that, looking forward to seeing that make some progress. And then also the Senate Finance Committee this morning came out with a youth mental health legislation package. I myself have been in meetings since 9 a.m., so I've been scanning it when I'm able to. It looks like there are some provisions for telehealth crisis services, nothing specifically 988 related that I've been able to tell yet, but we're going to do a deep dive in that and looking forward to seeing that. We don't know yet if that's going to be rolled into the Uvalde response package. We'll see with that, but it's exciting to see them prioritize youth mental health, and we're going to keep monitoring that.
Wonderful. Well, thank you so much, Sarah and Joanna, for those updates. I believe Stephanie has some state updates for us.
Yeah, thanks, Sarah. So no changes to the map this week, but some activity to quickly note. Vermont enacted its fiscal year 23 appropriations bill, H740. Just something to note within that package, it encourages the expansion of mobile crisis teams, including coordination with 988. And I'll actually ask my colleague Jordan Pantalone at Vibrant to provide a couple more updates.
Yeah, thank you very much, Steph. Hope everyone's doing well. Just 2 quick updates. The first in New Jersey, that's Senate Bill 311. That bill was amended and passed out of committee. The fee provision was struck from that, and that was changed to a study. So they'll be looking at that with a report due by April 1st of 2023. There is still some 988 funding in the budget that New Jersey has not yet passed. And lastly, just Rhode Island, that's Senate Bill 2467.
Jordan, I think we lost your audio when we were trying to mute some other folks. So you had gotten to Rhode Island and then we lost you for a second.
Sorry about that. Yeah, so Rhode Island, Senate Bill 2467. The original language there was replaced with appropriations that had included a fee. That appropriation is included in the governor's budget, which also has yet to pass. That's just under 2 million. So we are waiting on that to move through the Senate. Thank you.
Thank you both, Stephanie and Jordan, for those updates. All right, so moving right along, we're just 3 minutes away from when Secretary Delphin Rittmon is going to be doing her fireside chats. We want to make sure we get you guys off this call so you can join that. But just a little teaser about the next episode of Moving America's Soul on Suicide. Episode 7 featuring Craig Miller is going to be available soon. I, for one, am super excited about this. I've had an opportunity to see Craig speak in person, and I'm sure that this episode is going to be fantastic. So that's going to be available soon. So what's coming up next for the Crisis Jam? Looks like next week is an important episode you don't want to miss with Holly Rio talking about deaf crisis services. Also want to point out that the Assistant Secretary will be joining us on July 13th when 988 goes live. So that's another one of those can't miss episodes. So take a look and see kind of what the calendar is looking like coming up. And that's going to do it for our Crisis Jam for today. We want to give everybody an opportunity to join the conversation for that fireside chat. We've got the link back up here. And Stephanie just put it back in the chat again so that it's, at the very bottom of all your messages there, so you can go directly there from here. So don't miss also Day of Visibility tomorrow, the rally at 1:50 tomorrow. There's a link for that as well. So hope everybody has a wonderful day. Stay safe, stay cool, and we'll see you next week at the Jam.